All right, EMS systems. So let's get past all these competencies here. All right, so this is going to be a review from your EMT class. So for some of you that are fresh out of EMT school, it's going to be boring. For those of you who've been out of EMT school for a while, I apologize. You have to revisit all this. Unfortunately, EMS systems is going to be under National Registry exam. So with that being said, this chapter will describe the types of providers and different levels of care that compose this system. Okay, going from EMR to critical care paramedic, going through all the different realms that are there. Administration, medical direction, quality control, regulation of the EMS system, and also roles and responsibilities of the advanced EMT as healthcare professionals. Remember, what I want you guys to take out of your heads and change your way of thinking is we're no longer going to be technicians. We are going to be clinicians. There is a cause and effect to everything that we do. You have to know why you're treating patients, not just because the protocol says to do it, but why are we doing it, right? Okay. And I'll give you an example really quick, because this all falls under medical control, medical direction, things like clinician. If a patient has chest pain, the first thing we think about is aspirin, maybe nitro, right? Vital signs, everything looks good. But if the patient's showing presentation of stroke, along with having a STEMI, is giving a patient nitrates a good thing? Everybody should be shaking their head, no, that's not a good thing, because we're going to vasodilate, because we know that nitro is a nitrate that vasodilates, causing vessels to become bigger. If the vessels become bigger in the brain, it either moves the clot further in, or if it's a head bleed, it makes the bleed even worse, right? So there are certain times, because the protocol says to do something does not mean it's always right. You have to be a clinician and utilize your brain and the knowledge you get from class to make a clinical sound decision on how you're going to treat your patient, right? In the nursing world, they are considered clinicians. We need to change the way our profession thinks. We need to do what's best for our patient within our scope of practice. I'm not telling you to violate protocol by any means. I'm not telling you to violate your scope of practice. I'm telling you to think before you do something and understand what the cause and effect is that we do. If you give a patient epinephrine, we know it's a sympathomimetic. We know that it's going to cause increased heart rate, dilated pupils. There are things on the sympathetic nervous system that it's going to attack, right? That's the clinical side of things, the clinical way of thinking. And that's where I want to change your direction and set you up. Now, there are some of you in this class that may want to go to paramedic school. Maybe, maybe not. If you choose to do so, they're going to change your way of thinking like a clinician. I'm going to start that process now. Okay. So the EMS system consists of a system of professionals and agencies working together to provide a pre-hospital and a hospital emergency care to the sick and injured people, right? We have to work together. And when I start talking about medical conditions like distributive shock or something like sepsis, having an idea of what the hospital does makes a world of a difference in how you're going to start treating a patient in the field. That is why you do 75 hours of hospital rotations, to see what their world is like, right? To kind of see how we can prep for them to make things better. And to kind of add to that really quick, a patient having a stroke is going to get a head CT done as soon as you walk through those doors, especially up in the New Hampshire area. By putting a 18 gauge catheter in the right antecubital will allow them to be able to hook in on the side where all the ports are. It's amazing how you can make things better. If you can do IVs in forearms for patients who are going to get continuous IV antibiotics or therapies, the alarms do not start sounding on pumps because they can't occlude it by bending their arm. So there's ways of things that you can do to prep for the hospital for longer stay, because if you do it in the AC and it alarms and alarms and alarms, they're going to stick a patient again. That's something that we don't want to do, right? Multiple sticks, routes of infection. Let's limit that. If we can draw labs and cultures in the field as an advanced EMT, yes, you can draw labs in the field, right? That prevents the patient from being stuck again right away. Unless they got to get repeat labs, which sometimes they do for troponins. We'll talk about that later, right? So part of your local or regional EMS system that provides pre-hospital and hospital components required for delivery of emergency medical care. So for those of you that work in the Ospey Valley, I'm sure you guys all know Dr. Brown. Okay. He is very big on patient care, and you see him responding to calls. Okay? Those are those hospital, pre-hospital components that are there, having that training and education, talking to people at the hospitals, your clinical directors at the hospitals, talking with your clinical directors within your service, because it all blends together. But these are governed by laws in each state and typically regulated by a state EMS office. The National Registry is not a license to practice. It is a certification to obtain licensure within the state that you are there, working under the state and local medical directors, right? That's how that works. So people who provide emergency medical care, except for licensed physicians, must be certified EMS personnel or state licensed. A certification exam is used to ensure all healthcare providers have at least the same basic level knowledge and skill. Now, the National Registry says you will meet this standard. The state says, cool, we're going to give them a little bit more, like New Hampshire. New Hampshire has had epinephrine 1 to 10,000 for cardiac arrest for a very long time at the advanced level, and go back even to the intermediate level back in the I-85 days. Okay, Maine just got it. That's in the new protocol rollout. New Hampshire's had it for like 15 years. You can see the difference. All right. And one of the biggest things we're seeing is CPAP. CPAP is now down to the EMT level because of that. But it's all based on studies. All right. Licensure, the process which the state ensures applicant competency in an examination setting. This allows the states to manage who can function as a healthcare provider. So just because you pass your test and hold a license doesn't mean the state can't take it away. You still have to behave. You still got to follow your protocols. You still got to be a clinician. You still got to think. And if you're going to deviate from something, who do you call? Who do you guys call?
Medical control.
Yeah, medical direction. Exactly. Credentialing is a verification process of a healthcare provider qualifications, maybe local or regional. Right? Where I currently work, we do credentialing on a yearly basis. So on top of doing normal Con Ed, we do a skills evaluation on a yearly basis to make sure that your skills are up to speed. Right? That is a local requirement that my service does down where I am now. Okay, so it's all based on credentialing and making sure your skills are up to date. In most states, healthcare providers are characterized in 4 training and licensure levels. First one being EMR. So these are your first responders, PD, sometimes fire hazard as well, things like that. All right. You have your EMT, and the EMT level is trained for BLS and using AEDs, airway adjuncts, assist with administering certain medications. And you're allowed to transport in the back of the ambulance. EMRs cannot transport alone in the back of an ambulance. You have to be an EMT or higher. Okay. EMRs can drive. They can be in the back with another licensed provider that's an EMT or above as well. Right. But now we look at the simple airway adjuncts. Now the states have allowed CPAP and everything else in the EMT scope of practice, albuterol treatments, things like that. So things are changing. The advanced EMT, which you guys are all going to be at the end of this class, has advanced training in specific aspects of advanced life support or ALS, like IV therapy, certain medications, advanced airway management, like eye gels, king tubes, anything with supraglottic. Okay, you do not get into the paraglottic administration. Paraglottic would be like endotracheal tubes. And the paramedic level is trained to ALS, so ET tubes, emergency pharmacology, cardiac monitoring, and other advanced assessment and emergency medical treatments. Okay, so we have all that as well. So we get more into ACLS. Now, am I opposed to advanced EMTs getting ACLS? Absolutely not, because you have the ability to give cardiac epi. All right. So training and licensure requirements vary by state, but almost every state requirements follow or exceed the guidelines recommended in the current National Highway Traffic Safety Administration, the NHTSA, on EMS education standards. So a lot of them follow that. The standards are always updated and they are changing. And soon, for the National Registry, for those of you who don't know, in 2025, they are releasing the new model. And it'll no longer be the 2016 standard. They're going to be following the 2025 standard for hours required for your licensure in different categories. So you can adopt that now, but in 2025, everybody will have to switch. Right. So the NHTSA is a federal administrative source for education standards and related documents. So they set that standard for what we need to follow. And the state can go above and beyond, but they really can't take away from that national standard. So the AEMT training focus and requirements. So some patients will have life-threatening conditions and some will require supportive care. It all depends on what kind of call you're getting to, but that's when your clinician treatment comes into play in your assessment of what kind of care they're going to need, right? The excuse of people saying, well, the hospital's 5 minutes down the road. I don't ever want to hear that come out of any of your mouths at all. Why? Because we are clinicians. We need to treat patients. That's what we are there for, right? If you wait 5 minutes and transport BLS to the hospital, how long is it going to take for them to get treatment inside the ER, right? It could take an hour. It could take an hour and a half. It could take 20 minutes. We don't know. It all depends on how fast a physician can get in to do an assessment and prescribe medications and tests and treatments, where we have standing orders to start doing treatments. You as an AEMT have the ability to give CPAP, inline nebs, right? CPAP is reducing mortality. It is reducing the amount of patients that become intubated in the field. CPAP is great. This is a paramedic class. I'd be harping on BiPAP. It is phenomenal to utilize. At the AEMT level, you should be utilizing CPAP for your respiratory distress patients that need that crutch, that need that support. So look at your patient, do your assessment, and determine how you're going to make your treatment plan utilizing differential diagnosis. So some of the subjects discussed also include seeing size up. This lets you get that big picture, right? Tunnel vision is bad. Just because dispatch tells you you're going to a chest pain does not mean you're going to get there for a chest pain. Okay. We've all seen it. We've been in EMS for a while. Dispatch only can give us what they can get from the caller on the phone, right? I've seen patients that need to get a ride to town that have called in chest pains before. You get there and you transport. There's nothing wrong with them. You get to the hospital and they walk out. Thank you for the ride. And that happens a lot, especially more in the bigger cities, right? So EMS operates in a wide variety of environments. It can be dangerous EMS personnel, rural, city, backwoods country stuff. They're all there. So you got to understand your clientele. You have to understand your environment that you work in. The EMS provider must ensure personal safety. They make sure we're safe. And patient assessment, it's the foundation of any EMS call. You can't come up with differential diagnosis without doing an assessment. Vital signs, right? Heart rate, blood pressure, lung sounds, glucose. And keep going. Pupillary response, respiratory rate, pulse oximetry. And I'm going to keep harping on capnography, right? Waveform capnography, a BLS skill in New Hampshire. Not in Maine yet. Okay. All part of your assessment tools. And we're going to cover a lot on end-tidal monitoring. So I have a whole lecture I'm going to do separately on that one there for you guys. Preparing a patient for movement as a unit by means of a backboard, similar stabilization devices to medical care facilities. Now, I know we don't use longboards anymore for stabilization, but it is an extrication device. Stair chairs with tracks, without tracks, stretchers that are not power load. You got to be familiar with what you guys have for a service and utilizing teamwork so you don't throw out your backs. So take care of yourself. Remember, EMS is a career, okay? And it can be a long one, as long as you take care of yourself doing so, right? Ways to successfully cope with the job stresses. And I can tell you, this job puts out a lot of stressors. Those of you who've been doing this for a while, you know exactly what I'm talking about. You've all been to that call, right? Whether it be a good or a bad, right? We've all been to those types of calls before. So have an outlet, have someone to talk to, right? You must meet certain requirements that differ from state to state. So just because you get licensed in New Hampshire does not mean that you can start practicing in Maine. You have to get Maine licensure as well, do your protocol exams, and things are different. Vermont, New Hampshire, and Massachusetts, right? All different stuff. To know your protocols within the states. As far as requirements to be licensed and employed as an AEMT, high school diploma or equivalent, proof of immunizations against certain communicable disease, valid driver's license. Those are some of the requirements that you need in order to get a job. You also have the successful completion of a background check and drug screening. Remember, you are on ALS ambulances where a lot of times narcotics or controlled substances are stored and locked. CPR is a must and not heart saver. Okay. None of the layperson stuff. You have to have a healthcare provider class, whether it be through American Red Cross, AOS, AHA. It doesn't matter to me as long as it's something that is used for healthcare providers. You have to have a state recognized AEMT course. This course is recognized by the state of New Hampshire. It has a CREF number assigned to it. Therefore, it allows you to test and obtain National Registry certification. You will then take that certification to the state you reside in and want to practice in. You will submit that certification and whatever fees may be part of that. And then you will be able to attain your licensure. Now, you may be required to do a protocol exam and things like that. This class will give you everything that you need, including all your scope of practice stuff as well for New Hampshire licensure. Okay. There isn't much you guys have to do for Maine. It's really a protocol test online and watch the new protocol rollout that just came out if you haven't done so already. State recognized written exam certification exam. Those are the National Registry. And the practical exams right now, yes, they are still doing them. There is a process that's going through right now that's going to take away the practical assessments for EMT and probably at the advanced level. It'll all be tested within your class. Goes to demonstrate the ability to meet psychological and physical criteria necessary to safely and properly perform all tasks and functions described in the defined role as an advanced EMT. So compliance with other state, local, and employer provisions. Know the area you're working. There may be some local training you have to do. Like I can tell you now for the Osprey Valley, because I worked there for so long before I moved. There's STEMI bypass protocols, there's hypothermia bypass protocols, there's OB obstetric bypass protocols. There's different things because of the resources that are not readily available in the local critical access. Right. So you have to have an idea of which one you're going to go to, and there's training involved with that on top of your normal state requirements as well. Those are more of your employer provisions or state and local provisions. So state required written and practical examination may be the National Registry. Some states, and there are not many left out there, maybe one or two that are not National Registry. Right. I never thought Florida would ever switch over, and they did. So, and Massachusetts switched over in 2015. Requires recertification every 2 years to ensure continued competence. So when you go to recertify your A or recertify your EMT, you have to go through a process of getting enough hours. On top of that, your training officer has to sign you off. Now, I've seen some just do the random click and pencil whip it through. Then I've seen some training officers actually make you go through a skills lab in order to sign you off on the appropriate skills. And I've also seen medical directors for paramedics sign you off. So it all depends on what your service does. Most states recognize the NREMT. So it makes it very easy to move from state to state. So for example, to kind of add to that, my one certification relicenses in the 5 states I have licenses in currently. So it's one certificate, send it in, and you get recertified. It's not too bad at all. All right, so the American Disabilities Act, the ADA of 1990, protects people who have disabilities from being denied access to programs and services provided by state or local governments. Right, so people are protected. So to kind of add to this, if anybody in this class has any kind of special requirements based on the ADA, please do not shout them out during the class. Right, contact me directly, send me proof of documentation. I can do the best I possibly can to meet those needs based on any kind of disability you may have. Right, whether it be like learning disabilities, I just need to know. Right, that I can make certain accommodations or change times and things like that for your testing. Title I of the ADA protects those with disabilities seeking gainful employment under many circumstances. Employers with 15 or more employees are required to adjust process so a candidate with a disability can be considered for that position, right? And on top of that, when possible, to modify the work environment or how the job is normally performed. So contact your state EMS office for more information about the ADA and employment as an AEMT. And states must also ensure safety of their residents. So they may exclude certain people from AEMT certification, such as people with legal infractions or people with health problems that could make performance of an AEMT task dangerous. All right. So kind of the overview. Here we go. The history of EMS. So the history of EMS, obviously with field treatments and transports innovated during the Civil War. That's where a lot of things started. MASH units, things like that came into play later on. And a lot of the stuff that we had in our protocols really were derived from the military, right? Um, Especially trained corpsmen and that provided field care. It took casualties to aid stations in World War II, where there are advances in trauma care resulted from casualty experiences in Korean and Vietnam conflicts. So the conflicts in the Middle East and response to terrorism continues to influence EMS practices. So what they're saying is we're seeing better protocols because they're being tested out where they're seeing it in the war. They're seeing it in the military itself. So you're seeing a lot of especially trauma protocols. A lot of those trauma protocols are really derived from the military forces. So the United States, as late as the early 1970s, emergency ambulance services and care varied widely. There was not a lot. EMS as we know it today originated in 1966 with the publication of the Accidental Death and Disability, Neglect Disease of Modern Society. This report, commonly known as the White Paper, was prepared jointly by the Commission on Trauma and Shock, the National Academy of Sciences, and National Resource Council. So this revealed serious inadequacy of pre-hospital emergency care and transportation. So the Congress mandated two federal agencies to address these issues. One would be the NHSTA, or of the Department of Transportation, and the Department of Health and Human Services created funding for these programs. So states were required to focus on EMS personnel, training and legislation, and regulation of EMS levels. The DOT then developed published the first national standard curriculum as a guideline for EMTs as early 1970s. Right. So bringing back some memory from you guys from EMT classes, where were some of the first paramedics in the United States?
LA.
What was that?
LA.
LA. Anybody else have any ideas, thoughts? So there were three areas that had a lot of the paramedics that were started. Some of the first ones were Miami-Dade Fire Rescue in Florida. Right. A lot of the other paramedics were started by physicians, Cape Cod, Massachusetts. Some of the first paramedics in the United States were based out of there, done by physicians. And then Los Angeles as well. So the American Academy of Orthopedic Surgeons prepared and published the first EMS textbook. The abbreviations being AAOS, the same textbook that you are currently using now. Obviously updated since 1971. Right. Through 1970s, each state developed legislation and EMS systems were now created. So during this same period, emergency medicine became a recognized emergency medical specialty, and fully staffed EDs became the accepted standard of care. In the 1970s, the DOT then developed a recommended national standard curriculum for training of paramedics and identified a part of the course as be served for training for advanced EMTs. During the 1980s, many areas enhanced the EMS national standard curriculum by adding providers with higher levels of training who could provide key components of ALS. Now is the biggest thing is getting advanced life support to the scene. Everybody can remember the show Emergency. Right. And it's amazing because they were transmitting 12 leads back then. And imagine that, we're doing that now. So pretty interesting stuff. And you mentioned, and who mentioned, I can't see all the cameras right this second. Who mentioned Los Angeles?
I did.
All right. So interesting thing about Los Angeles, you know, about a little bit of history of EMS. They have an ambulance out there called NP1. What do you think that is? It's a nurse practitioner ambulance that responds out to calls. They also have, well, I'm going to call it a drunk bus, but they have an ambulance for intoxicated patients as well. So they're pioneering a lot of this stuff. Imagine that, a nurse practitioner responding to the scene in an ambulance and transporting. Yep. So they have those out there as well. So a lot of things are changing. So in 2019, the NHTSA revised an EMS agenda for the future and published the EMS Agenda 2050 to place greater emphasis on patient-centered care. And that is where clinician is starting to come into play. We're starting to see a lot of these studies now. So all those little drop-down boxes you guys hate to fill out in run reports, it gets reported to NEMSIS. That helps with these national protocols and changes. Right. So, all right. The licensure of AEMT is a state function. So variation in practice, training, licensure requirements. The federal level, that's your national EMS scope of practice, which provides guidelines for the minimum skills each EMS level provider should be able to perform. That's at a federal level. Now, I mentioned before, that's our national registry stuff, right? Now, the state laws regulate how EMS providers will operate. So that gives us a little more leeway or more protocols to be able to utilize. But then you have your medical director, which is day-to-day limits of EMS personnel. The local level can then give you even more stuff if they choose to do so. So there's always going to be something called statewide treatment protocols, but then they have local level, which could give you a little bit more. Like down here where I'm working now currently, there are some services that are carrying blood products, but it's not a statewide protocol. It's a local level that was allowed to take a little bit more. So they can carry whole blood products to give to patients in trauma on a normal paramedic ambulance. So the medical director can limit the scope of practice, but cannot expand above state laws, right? So your laws have to have that. So within the RSAs of New Hampshire. So public basic life support, BLS, and immediate aid. Millions of lay people are trained in BLS CPR. Okay, the lay person stuff. Teachers, coaches, babysitters. The American Red Cross has a babysitter course. The American Heart does not have one, but they have something called pediatric first aid. So there's different things that are out there, and they're being taught. Hands-only CPR is a huge thing. They made a huge push for that years ago, about 2015, 2016-ish. They had a big push for that. BLS courses are designed for lay people to provide critical care before AEMTs or other responders arrive as well. AEDs are becoming more and more popular. There's grants out there for that as well. So what I can tell you is that the town of Wolfboro, New Hampshire got a grant for 50 AEDs to be placed throughout the community and in their police cars and their engines and ambulances and whatever else is out there, right? They got a grant for that. I want to say it was through the COVID grant. They got it for it. But again, we're starting to see more and more and more out in the public. And then they become heart safe communities, which is another designation project that's out there as well. So these are designed to be used by untrained layperson, including entry level or every level of pre-hospital emergency training. There are some bigger cities that are utilizing something called Pulse Point. Have you ever heard of that before? Have you heard about Pulse Point? Literally, a dispatch center puts out what they call a pulse point to people's phones. There's a cardiac arrest in the vicinity that they're currently walking to go over and start CPR. People that are trained and have this app on their phone, it will set off an alert within like a certain block radius that there's a cardiac arrest. They're also using drones. I've seen a lot of that as well, where they're taking drones and from dispatch centers and they're flying them out and to different locations with an AED built into it. And it gives you all the directions on how to use it. So again, technology is crazy. So EMRs, going back into this really quick. EMRs, law enforcement, park rangers, ski patrollers, firefighters. Now, Lucas is ski patrol, and you guys have a whole different protocol set anyways, right? I think he's there somewhere. But ski patrollers definitely have a different protocol set than what EMS does. EMR training provides skills necessary to initiate immediate care and assist other EMS providers upon their arrival. Focuses on providing immediate BLS and urgent care with limited equipment. Right. So the neat thing about that is that one of the things, well, we're not EMT yet. My apologies. We'll get the EMT in a second. So EMRs may be called to assist with packaging, first response, and things like that. The EMT course requires about 150 hours or so, a little bit more. Provides the essential knowledge and skills to provide basic emergency care in the field. So again, it serves as the foundation, but then we take that foundation you learn in EMT school, and we build on that and change your thinking process. So the arrival of seeing AEMT and other providers who respond with the ambulance should be able to assume responsibility for the assessment, care, packaging, and transport, if appropriate, of the patient to the emergency department. You will now be a higher license level. So when you're on a call with an EMT, they look to you, right? You are going to be the man in charge, man or woman in charge. So the advanced EMT also training course has a minimum of 200 hours beyond EMT requirements. This class is very close to 200, including clinical rotations. You're actually way above that. You're about almost 300 hours, 300 plus hours of time, including clinicals. So it delivers an expanded range of skills beyond the EMT, like IV therapy, as you can see in the photo here. Provides limited ALS care to regions where paramedics are not available. AEMTs play a huge function, and about 85 or 90% of the calls we do really can be handled at the advanced EMT level. Paramedics really aren't needed for those. Now, the paramedic curriculum ranges between 800 to 1,100 hours. Beyond that, I can tell you when I went through medic school, I had to do 1,000 hours of clinical rotations on top of going to school for 2 years. Right, and add another 6 months for critical care on top of that, doing 10 hours a week in class time. So I'm increasingly offered with the context of an associate or bachelor's degree college program. So you're not seeing a lot of the normal paramedic like bridge classes, and it's still out there, not as many, but a lot of places are looking for that associate's degree in paramedicine. So the EMS Agenda 2050 is a multidisciplinary national review of all aspects of EMS delivery. So the goal is to develop more cohesive and consistent systems across the US. One of the things that I haven't seen much movement on is a New England-based protocol set. I know that they were working on that. If you notice, though, Vermont, Maine, New Hampshire, and Massachusetts, the protocols look identical as far as the layout goes. So we're starting to see that change now. So the document features 5 key aspects of people-centered EMS systems. And you're probably going to see this on your quiz. Comprehensive, quality, and convenient care, evidence-based clinical care, efficient, well-rounded care, preventative care, and comprehensive and easily accessible patient records. Wouldn't it be nice if we had the ability to look up a patient in Epic or in a system that the hospital uses that we transport to get all the patient demographics, information, history, and physical to be able to treat a patient? Wouldn't that be awesome if you could log into a system like that and share resources? Right? Preventative care, community paramedicine, right? Going out into the field and helping people out like that. Evidence-based clinical care. Those are those silly drop-down boxes we fill out. Right? That's building that evidence-based medicine, evidence-based care that we see. So the vision of the EMS Agenda 2050 is that people-centered EMS system is one in which people receive comprehensive quality care in the most comfortable and convenient place. We started seeing more of that during the height of COVID. Why? Because we told people, we're not taking you to the hospital. We can treat you here and let you go. There's no need to go. Right? Now, EMS initiated refusals can be dangerous. Okay. But there are certain circumstances with conjunction of utilizing medical control to leave somebody at home that does not need to go to an ER. Right. And that's coming. And you're going to start seeing telemedicine even more in the field. Right. There are some services in Massachusetts that are doing community paramedicine now that are using telemedicine with physicians while on scene. It's coming soon. All right. So inherently safe and effective, right? So the entire system from start to finish is designed to minimize exposure to injury, infections, illness, and stress. Integrated and seamless, where EMS is fully integrated with all other aspects of healthcare and is engaged with other emergency services and within the communities in which they operate. Like I said, we just talked about this, right? Having the ability to see patient records in the pre-hospital setting will help us with patient care. Reliable and prepared, right? Sustainable and efficient, socially equitable, adaptable and innovative. Look at all these different things that are there that'll help evolve and meet the needs of the people. That's what we're here for, is to serve the public. We're providing everything that we need. Right? New Hampshire has allowed paramedics now to utilize what they call POCUS, POCUS. It's point of care ultrasound to do fast exams in the back of an ambulance to help treat trauma. It's amazing some of the things that are coming out. The ability to point of care testing, utilizing ISATs to help with treatment and care of sepsis. There's so many different things that are coming out now that are phenomenal, that are helping with patient access and patient care and becoming more of a clinician in the field. Right. So public access. Trained dispatchers obtain information. EMD. Alpha Bravo Charlie Delta Echo Omega. Right. EMD certification. EMD designations to assist in response. Communication center, usually at the public safety access point, what they call a PSAP. Enhanced 911 systems, the address of the caller is displayed on the screen. When you call 911, it displays. In theory, it should work that way. The address remains on the screen until the dispatcher releases it. If the caller is able to speak or hang up, the location remains displayed, right? They use GPS coordinates and everything else so they can actually find cell phones that are being operated. They can ping those areas that they're in. In some areas, rather than 911, a different special published emergency number may be used to call EMS. I don't know of many places now that use a 7-digit number now to call 911. You may see that more in like industrial, where they have to call like a 4-digit number or whatever, or whatever they utilize to get a hold of public safety. But I don't know of any place right now that's not using 911 in a setting that's in the public. If somebody else knows of one, please shout it out. I just don't think there is anything else out there now. Train the public on how to use Summit EMS unit is an important part of the public education responsibility, right? Fire Prevention Week, EMS Prevention, EMS Week, EMS Prevention Week, everything that we do in the field is opportunities to educate. So an emergency medical dispatch system was developed to assist dispatchers in providing callers with vital instructions until EMS arrives. Is anybody in the class a dispatcher at all? Keep in mind that I can't really see everybody on the screen right now, but man, I just brought it back up. Is anybody here a dispatcher? No? All right. And in Maine, the EMD certification is a Maine EMS license. You have to recertify that as well. What they do is they follow a bunch of cue cards, but it's all obviously on the computer now. But they also have flip charts if the computers fail. So if you ask this question, you have chest pain. Okay, it goes to chest pain. It becomes a delta level. Now they go to different other questions that are in there, and they can actually start EMDing. They cannot give medical advice over the phone. They can't go rogue and start giving their own treatment plans. They got to follow a cue card that's set. All right, so communication systems from the caller information, the dispatcher selects the appropriate parts of the emergency system to activate, whether it be EMS or fire, PD, whatever needs to go. So a part of the police and fire department. They are independent sometimes as well. Like Action Ambulance, they're an EMD system. They actually EMD calls down and they get transferred from a PSAP to them. They EMD the call. So contractors providing ALS or BLS services. So there are places that run what they call a tier system. And Exeter Hospital has that system over there, where they have anything that's Delta or Echo level calls and some Char level calls. They'll automatically dispatch the paramedic intercept unit out of Exeter Hospital to respond along with the ambulance service that's going to their town. So they have tier response systems in providing ALS or BLS. New technology helps responders locate their patients, such as cell phones linked to GPS units. So again, being active in your community will help keep you on top of the best local resources that are there. What can you utilize? Now, clinical care. Again, get rid of that technician, become that clinician, and start using differentials to treat your patients. So they use a wide range of emergency equipment. AEMTs, the course will help you learn the equipment that's there, or when it is indicated and when it is contraindicated. Like I said before, you have a bunch of tools at your disposal. The question is, do you know when to use it? Is it in its assigned place? Is it working properly? Are you familiar with a specific model? So again, you should never put a new piece of equipment into service until you're trained on it. There should be a global training throughout your agency. Everybody should be signed off on it, and then it goes into service. If you just toss it onto a truck and someone doesn't know how to use it, that could be a problem. Because those are part of your new hire orientation process. So make sure you guys are, if you're involved as an FTO or training officer, make sure you're looking at that. And if you want to talk more about training officer stuff offline, feel free to give me a call. I've done a lot of that over my years. You may be called to drive an ambulance. Maine EMS requires you to have an emergency vehicle operations course, whether it be EVDT through VFIS or the Maine AVOC, within 6 months of hire. That is a state requirement, and you only have 2 different things you can utilize, right? Unless approved by Maine EMS. New Hampshire does not have anything for EMS operations. Fire is a little bit different, but EMS is not. There is no actual requirement. Now, services may put you through something called CEVO or EVDT or an online program with no driver training on the road. That is up to the service to be able to do that. For some reason, the states really don't push very hard for EMS operations with laws as far as driving goes. Some states do, some states do not. Maine has a pretty good one, though, for EMS. Before you go on duty, check equipment, do your truck check. I mean, I should have to go in detail on this here, right? Go through your trucks, make sure your equipment is there. The way I do it, when I'm on a truck, which is rare, but when I'm on a truck, I look at the basics I need first. Is there a monitor? Is there a battery? Are there electrodes? Is there oxygen? Do I have my medications? Is my first in bag ready to go? Can I do one call with everything that's currently there? If I say yes, then I can do my more detailed check, right? But I want to make sure I have the basics that I need to be able to treat a patient if the tone drops 2 minutes at the beginning of my shift. And hope to God that the previous crew restocked the ambulance. All right. This is your first time driving a specific ambulance. It's good to take it out before you respond to a call. You should not be driving an ambulance until you are certified to drive it. Right? That's through your new hire orientation that you provide, whether it be through a fire department ambulance or even EMS. There's always going to be that training period before you start on the road and work a shift. That's when all that should be done. Ambulances are different. Some are toggle switch inside, some are complete computerized systems. I like the toggle switch, keep it simple. Right. So human resources deals with a patient, people within the EMS system. The overarching concept is to encourage the creation of EMS systems that provide an environment where talented people want to work and can turn their passion into a rewarding career. Right. There's somebody that I used to work with in New Hampshire that always told me, I don't want to have to come to work to work. And I said, well, that doesn't make me feel comfortable. He goes, that's not what I'm saying. I want to work, but I want to do it. I want to have fun while doing it. If I had to come to work and count down the hours before I get off shift, then something is wrong. Why am I not happy being here? He made a good point. Go to work to have fun, right? Enjoy your shift that's there, right? The EMS Agenda of 2050 encourages systems to help protect the well-being of the EMS provider, develop career ladders. You shouldn't just be stuck at one position. You should have the opportunity to grow, right? Offer educational opportunities for leadership if you want to go down that route, or moving up from EMT to advanced EMT to paramedic, and offering the courses in house. Efforts being made to ensure EMS providers can relocate from one state to another more seamlessly. For me to relocate from the north to the south was very, very easy. National Registry, get some fingerprinting, background check, everything cleared out. I have a license. That's seamless. It should be easy to move forward. So one of the functions of the National EMS Scope of Practice model is to create a stable foundation, right, on which each level of EMS provider is grounded. National Register certification often facilitates licensure in other states, right? So replica, which is recognition of EMS personnel, licensure, and interstate compacts. Now, New Hampshire used to have something called, I'm not sure if they still do or not, I could be wrong, but they used to have something called a waiver. And you could get a waiver to practice EMS for like a week. And New Hampshire Motor Speedway used to have that with Golden Cross Ambulance and Speedway Safety. When they had the big races, they had to get people from all over that wanted to come practice. They used to do EMS waivers, allow you to practice at BLS for a week. I'm not sure if they still do that or not, but they used to. All right, medical direction and control. We're just going to kind of finish this up. We're getting close to the end. And we'll take a break and then finish up the last chapter. Medical control and direction. Each EMS system has a physician medical director, right? You should know who they are. If there's anybody that's in the room, in the class, that doesn't know who the medical director is going into advanced school, learn who they are. You need to know their name. All right. Standing orders are part of protocols that designate what an AEMT is required to do for a specific complaint or condition. Protocols are comprehensive guidelines, right? Going in detail on your scope of practice, right? What are protocols? Policy, or are they guidelines, right? They're guidelines or a guide. You can deviate from your protocols, but if you're going to do it, you better call med control first. And you better have a reason why you're deviating from that. Okay. Providers are not required to consult medical direction before implementing standing orders. If you have a standing order, you are not required to contact medical direction. However, there's nothing wrong with consultation. If you think you might be going down the wrong road, contact a physician anyways. Talk to them. Even if it's standing orders, say, listen, my gut says don't do this. My clinical evaluation says the protocol says to do this, but I think it's going to harm the patient. The doctor may go, you're right, don't do it, even though your protocol says to, right? But if you do that, document it. Consulted with medical direction, both agreed to not perform this medication procedure, right? And then document what you did and what you haven't done. That's good. That's good documentation, right? And quality assurance will actually compliment you for being able to have that consultation. Medical director is the ongoing working liaison among medical community, hospitals, and AEMTs in the service. Remember, as an AEMT, you're providing advanced medical life support, right? You're providing advanced stuff. So medical control can be online or offline, as authorized by the medical director. Online direct is a physician direction given over the phone or radio, can be communicated by the physician's designee, right? A physician's assistant cannot give you orders. They are not a doctor. A nurse practitioner can, and a medical doctor or a DO. Nurses cannot act as medical direction. Hospital paramedics cannot act as medical direction. If they do, they are violating state protocol. Right? Offline would be your standing orders or anything approved by a medical director. So some places, like down here where I work, they have offline standing orders that are above and beyond what the state protocols allow. because a doctor has signed off on it saying you can do this. Now, for example, New Hampshire, DART, flight service, right? Critical care medicine. They go to scene calls, they provide pre-hospital care, but they can do a lot more. Why? Because they have a medical director that has been signed off on those providers to show the skills. Finger thoracostomies, RSI, and things like that are all done by the paramedics. Placing of chest tubes, and things like that. Those are all critical care skills, but allowed to be done in pre-hospital setting because the medical director has signed off on that service. Does that make sense to everybody? And how that works? All right, cool. All right. So EMS is usually administered by a senior EMS official, right? So if the EMS unit is part of the police or fire department, an assistant chief manages EMS activities. There are still some out there that are still run by the PD. Massachusetts, the only one that I know of in Mass is Billerica EMS, is owned and operated by the police department. So you have to work for Billerica PD in order to be part of EMS. Right. The chiefs or executives, managers, director of operations, those people are responsible for purchasing, vehicle maintenance, budgets. They kind of oversee everything that's it. Those are your chiefs. Okay. All right. I really knew about that one there. So the integration of health services, obviously the pre-hospital care you administer is coordinated with and care administered at the hospital. Sepsis is a big one that's out there right now, and a lot of states are doing this, and they're working in conjunction to provide better care. So early antibiotics, the acquisition of lab work, cultures, giving antibiotics, these are all paramedic level things, but again, we're starting to see that transition. But as an advanced EMT, getting that blood work, getting those cultures drawn if the service allows you to do so, that's huge. That's amazing. Because then they can start antibiotic therapy faster. Right? Other ones, heart attacks, traumas, and strokes. You can call in stroke alerts. Now you're bypassing the ED, going right to a head CT to rule out any kind of bleed before they start getting into stroke care at the hospitals. And they're doing something called telestroke, where they have a neurologist at critical access hospitals now that are done through a video conference to determine whether or not patient can receive TPA or those clot busters. It's amazing how the system's working. Same thing with the heart attacks or the MIs. Bypassing local hospitals, getting a paramedic on board, giving heparin, nitro drips, and going directly to a cath lab. You know, trauma, same thing as well. Bypassing the trauma centers, going to level 1, level 2 trauma centers that have neurosurgeons on staff. Mobile integrated healthcare. This is your MIH or the community paramedicine. If a patient is discharged from a hospital and has to go back in for the discharge diagnosis within 30 days, the hospital has to eat the cost of that patient. They don't want to do that. That's where community paramedicine came into play. They're discharged, and the community paramedics work within the hospital system, and they help prevent them going back. Why? Because sometimes it would be something very simple that can be treated in the field by a medic. Or how about sutures being removed, right? People go to the ER to get their sutures removed when a paramedic could respond out in a fly car and take them out on their own. EMTs can take it out. It's that simple. Pull sutures out. Taking blood pressures, assisting with medications. And this is all done through screens with mobile medicine, talking with a physician through telemedicine with an iPad. Now you're with a doctor right on scene, virtually, treating patients by their bedside. Right? This stuff's happening now. We're starting to see more of it. You know who has a really good system like that? Is Cataldo in Mass. They have a phenomenal MIH system. Evaluating quality and safety. The medical director maintains quality control to ensure all staff members meet appropriate medical care standards on each call. CQI is huge, right? For those of you that worked with me before, I know that I did a lot of CQI stuff and I kept on top of it. And a lot of the people that are that took over my positions when I left, they do the same thing. They review calls. That is their sole purpose in life, is to read run reports all day long and then run calls on top of that. That's what they're supposed to be doing, right? There's a lot. CQI is good though. Quality insurance, continuous quality improvement, or QA, quality assurance, right? Works in the system as long as everything's in place. If I see a trend under quality insurance, then I take it into quality improvement to make a change in what we're doing to make it better. That's what we have to look at. I don't know if any of you in the class is quality assurance now. If you want more tips and tricks, I'll talk to you guys offline about it. But let me know. Refresher training, continuing education are also important. You should be doing monthly education, shift training, all that kind of stuff exists. Question is, you're going to do it, right? Skill decay may occur as well. I say that to a lot of paramedics. When was the last time you intubated somebody? Oh, it's been like 5 months. Okay, well, let's put you on a mannequin and start practicing. Let me get you into the OR and practice some tubes. Or I haven't done an IV in 3 months. Okay, well, let's put you on a mannequin arm. If you're having bad success rates, put you in the ER for a little bit. You can do some IV time, get your skills back up. There are ways to fix things. Another function evaluation process determine ways to limit and eliminate human error and improve patient safety. It's all about quality assurance. Right? Driving to the scene. Camera systems now in ambulances. I get notifications all the time if we have a hard braking, speeding, accidents, hard turns. I get a notification on my phone through Verizon for my ambulances down here. All the time it's going off. Then I call the crew, slow down. It even records it too, and I get video footage. Eliminate errors as much as possible. That's what quality assurance, quality improvement does. There are 3 main sources of errors. One is rule-based failure. Number 2, knowledge-based failure. 3, skill-based failure. And 4, adding to this 3 main sources, but 4 being any combination of these can occur simultaneously. Right? Agencies who need to have clear protocols that understand by all AMTs in the service. Right? Eliminate errors as much as possible. Review calls. When you're about to perform a skill, ask yourself, why am I doing this? This is the clinician part of you. A differential diagnosis says I need to do this. This is why I'm doing something. Don't do something because the protocol says I can. Do something because you know why you're giving it. Understand the pathophysiology behind it. If I'm giving a patient a medication, I expect this to happen. If it's not happening, what's the problem behind it? Are they having a bad reaction? Or are we actually getting that therapeutic effect that we're looking for? That's what we need to look for when we're giving meds. We're doing procedures. If I give somebody IV and fluids, what do I expect to see? Right? That's what you guys need to be thinking about. This is why I'm giving it. Right? Just because we give fluids does not mean it's a good thing. Remember, normal saline is not that normal. Discuss troublesome calls with your partner and or supervisor. Right? I'm going to actually underline this one here. Right? Talk to people. Suicide is way too high in EMS and fire and public safety. Have that conversation. Find your outlet. Right? Another one here too is cheat sheets. I love apps. Right? There's a lot of medical apps out there. Pediatrics, we don't see a lot of those, do we? There's an app called PD Stat. It's like $4.99. It will be your best friend. Right? Hippocrates, free. Great resource for medications. Wiser, great resource for hazmat, especially for treatment plans. A lot of good things that are out there. All right. Let's see. Almost there. Well, let's finish this one here up, and then we'll take a break and then finish up the last chapter. We're on slide 51 of 65. So All EMS systems are allowing EMS systems to efficiently document emergency medical care that has been delivered through information systems. So again, kind of going over this stuff here really quick. Information is used in a variety of purposes. Purchasing of new equipment. So if we're seeing an abundance of calls, you might be able to buy new equipment or equipment to help with that type of call. It justifies hiring more personnel and it constructs educational sessions for the department. That's the big thing for you to know. Drop downs help with NEMSIS reporting. NEMSIS reporting helps develop national standards. All EMS departments need a functioning system that allows them to continue to provide care. Right? There are several types, paid, volunteer, or combination that are out there. Right? So financial resources are available for EMS departments through taxation, fee for service, paid subscriptions, donations, fundraisers, federal, state, and local grants. Whether you're a private nonprofit, private for-profit, government, municipal, local government, doesn't matter. There's funds out there somewhere to help offset this. Medicare, though, however, has low reimbursements. Private insurance is actually better to bill, but again, patients still need to be transported. Right. So the 2020, the CMS implemented emergency triage, treat, and transport, called ET3, which allows transport to EDs for patients who need that level of care. Right. Payment model for patients transport to alternative destinations. Urgent care centers, doctors' offices, or on-scene treatment with no transport. Right. We do not transport to these. Okay. We don't do these kind of transports in 911. Freestandings, yes. Urgent cares, no. Right. So again, some things to think about. As far as education goes, I'm not going to hit this really crazy. You want to talk about education later? We can do that. KHAP and COAMPS are two accreditations and commissions on educational programs. All right. So I have to follow those when I'm teaching an advanced EMT class. We have to follow those standards and accreditations. We're seeing more of the COAMP accreditation in paramedic programs. Right. And New Hampshire is switching over to EMT and AEMTs to meet that COAMP accreditation. ALS level instructors and directors must hold a 4-year degree. Right. So when you're teaching paramedic critical care, you should have 4 years of college under your belt with a degree behind it. Right. General ALS training is provided either in a college, university, adult career center, or hospital setting. Now they're talking about paramedic schools for these ones here. Right. The freestanding paramedic schools aren't happening anymore. Right. Now I know that Action Ambulance is doing a paramedic program. They're COAMP and KAP accredited. They went through and they're also affiliated with a college as well to make that happen. They have the college affiliation. Right. EMTs in advance, that is not happening currently. All right. So components of the EMS where it's focused on the public health. So obviously, we don't do a lot of this stuff here as far as what we do as AEMTs. However, during mass events like COVID, we may be called to assist the public by doing different vaccine clinics, things that are outside of our norm. All right. But those are done by special protocols. Also, we work with health agencies on 2 strategies, primary prevention and secondary prevention as well. As far as research goes, without kicking a dead horse in this whole thing, EMS research is very important. That's what builds our protocols. That's what helps. There's something called a Pegasus study, which was done in Texas. Because of that, your pediatric protocols are the way they are in New Hampshire, Maine, Vermont, Massachusetts. Okay, it's because of that Pegasus study. And a lot of the states now share the same pediatric protocols. All right. So again, it's important to make sure you're filling out those drop downs. Transport to specialty centers. I'm not going to go over all the ones in New Hampshire. There's so many different ones that are there. There are only 2 centers in the entire state of New Hampshire that provide ECMO. Dartmouth and Portsmouth. That is it. So with those New Hampshire providers, take a look at your protocols under hypothermia. Look at that stage 4 hypothermia protocol. Right. We'll cover more of that later when we get into the hypothermia environmental emergencies. But There are different levels of hospitals. There are critical access. That would be your Memorial, your Huggins Hospital for your area up there. That's your Sanford Hospital for those who go to Sanford. Then you have your level 3 trauma centers. You have level 2 trauma centers. You have level 1 trauma centers. Your level 1 centers have a 24-hour on staff in the hospital neurosurgeon. They're also a teaching hospital affiliated with a college or university. Right. Portsmouth Hospital, the only thing holding them up from being a level 1 is they have no college university affiliation at this point in time. They're not a teaching hospital, but they have 24-hour neurosurgery on staff. So know your protocols, know where you can transport. Interfacility is not just bringing a patient back to a nursing home. There's critical care transport. There's in New Hampshire, they allow AEMTs to use cardiac monitoring and a non-cardiac diagnosis for transports in a facility. There's a lot of different things that are out there. This will take another whole day and lecture, but understand how your system works, right? Dialysis patients, everybody probably shakes their head. Oh my God, a renal roundup, right? So we're not going to be. Hold on a minute. Your patients in renal failure or chronic renal failure, end-stage renal disease, those are some of the sickest patients you're going to transport as an EMT. I asked students, prove me wrong. Their labs are so out of whack. Sodium, potassium, chloride, all these things that help make the heart tick. Your electrolytes and imbalances because they have no renal function. Okay, those are your sick patients. And we're taking these patients, and I've seen EMTs sit by their side or behind the head, no vitals, nothing. These patients are very sick. So again, treat your patients, do vital signs. You never know, you might find something actually wrong with them and bring them back to a hospital. Working with the hospital staff, again, be familiar with the hospital by observing. I know that a lot of the crews where I used to work up in New Hampshire, if you brought a patient who was critical into the ER, you stayed and helped, and you worked with the ER staff until they had enough, the patient was more stable. Whether we doing compressions, to doing more IVs, to assisting and pushing meds, to whatever it may be, you're asked to help, and you help. Right? That just builds more character. It also helps with the ability to work with medical direction. They get to know who you are, and when you're looking for those specific orders, they're not going to question you. On top of that, physicians or nurses may teach you as well. Working in the public safety agencies, again, working with fire and EMS, just be familiar with what they can and can't do. So, roles and responsibilities of the AEMT. I mean, you guys can all look at this here. I'm not going to get too in depth in it. Professional attributes. Don't come to work and be lazy. Okay. Study, learn, open a book, do some online training, right? Doesn't mean you have to do it for the full 24 hours, but if you can carve out 2 hours of your day to do some educational stuff, it keeps you on top of things. All right. And last slide here is every patient is entitled to compassion, respect, and the best care. I don't care if you're going to that frequent flyer that you see 4 times a shift. That last time, they really could be sick. I have seen crews in the past, and I'm not going to mention the service names, but they've gone in and didn't do assessments, signed them off, and 3 hours later, the patient was dead. Or they didn't bring that monitor and do that 12 lead, contact medical control, patient was dead 3 hours later. Let's not be that crew, all right? Remember, whether you're paid or volunteer, you are a healthcare professional either way. All right, it's 8:36. Let's come back at 8:45, and we'll finish up with the last chapter for the night. Does anybody have any questions at all in regards to what we just covered? No? All right.